So radiotherapy as a modality in the management of cancer is invaluable. It's been demonstrated in multiple tumour sites to offer a curative approach to a patient's treatment. What we've known for many years is that when you combine radiotherapy with chemotherapy, you see a synergism between those two modalities. So it's quite common in lung cancer and other tumour types to combine radiotherapy with chemotherapy, as it helps to improve the radiosensitivity of the tumour. Effectively, you're able to kill more cancer cells than you would normally with radiotherapy alone. In terms of what radiotherapy does, it can alter the environment that the tumour lives in. It can also help the cancer to express other targets that you can potentially use to your advantage by introducing new drugs. The new drugs that we currently have under investigation are ones that improve the radiosensitivity of cancers, but they can also be helpful to try and make the normal tissues around the cancer more resistant to radiotherapy. Recently, there's been data presented in lung cancer that's demonstrated that when you add immunotherapy to chemoradiotherapy for stage 3 lung cancer, you can see a significant improvement in overall survival. We are now able to offer our patients adjuvant immunotherapy once they've completed chemoradiotherapy, providing their cancer displays the marker which predicts sensitivity to immunotherapy. Other trials are currently ongoing. We hope to explore whether the addition of immunotherapy after surgery is helpful, whether immunotherapy after stereotactic radiotherapy, which we utilise for early lung cancers, is also beneficial. And these trials, we hope, will reveal that there is a benefit to our patients. Over the past 30 years, there's been a dramatic improvement in the technology that we utilise in the delivery of radiotherapy. This has come about through developments in imaging and computer technology. Radiotherapy is all about targeting tumours within the patient's body. And as a radiation oncologist, what I want to make sure is that when I deliver that radiotherapy, it's delivered to the tumour and not to the normal part of the patient's body that surrounds that tumour. To accomplish that, we've now begun to integrate new diagnostic modalities of imaging. So we're now utilising MRI, we're utilising PET, CT, ultrasound, so that we can identify precisely where the tumour is, so that when we switch the patient's radiotherapy on, it's directed towards the target, the tumour, and not to the normal part around the tumour. Achieving this means that we're more likely to cure patients of their cancers, and that's important, obviously. It also means that we can potentially reduce the side effects and toxicity of radiotherapy, which again is very important. Following on from the advances we've made in imaging, we're now able to offer patients highly targeted treatments, which allows us to deliver very high doses of radiotherapy over a very short period of time. We term this form of radiotherapy stereotactic body radiotherapy, or in the context of treating tumours within the brain, stereotactic radiosurgery. Essentially, we're now able to deliver a dose of radiotherapy that kills the cancer. And we are able to do this safely because of the advances we've made in imaging. What's been shown recently in clinical trials is that there's a group of patients that we now term oligometastatic. They're patients with a low volume of disease in a limited number of sites in their body. By using this form of radiotherapy, this highly focused and ablative form of radiotherapy, we can effectively eradicate those colonies of cells in the different organs within the patient's body. What's been very helpful recently is that trial data has begun to emerge that validates this approach to patients. Very recently, in the ASTRO conference, there was 2 studies presented which demonstrated that stereotactic radiotherapy for oligometastatic disease can have a huge impact on the patient's progression-free survival, but also their overall survival. And I think it's those trials that are validating this approach to patients' management. As radiotherapy continues to evolve, I predict that we're going to become ever better at defining our tumour target and delivering radiotherapy with greater precision, with less toxicity, with better outcomes for our patients. It means that we should be able to define the target and able to treat the target, minimising the dose of radiotherapy to the surrounding tissues. What we're beginning to see is that our survival rates from patients treated with radiotherapy are improving. And patients living beyond their cancer, it's important to remember that we want to minimise the potential morbidity of those treatments so they lead healthy and normal lives with normal durations. We've already seen in the context of radiotherapy in the past for lymphomas and breast cancers that you can cure patients of their disease, but those patients have to live with the potential complications of that treatment later in life. As we see advances in systemic drug treatment, as we see advances in surgery taking place in parallel to radiotherapy advances, what's becoming clearer is that it's important to integrate all these modalities of care so that you obtain the very best precision from those different treatments to optimize the patient's outcome and minimize the potential morbidity and toxicity of those treatments. Therefore, I think it'll be important as time goes on that every patient's discussed in the context of a multidisciplinary meeting where these different treatments are projected onto the patient's case and their case is individualized to their cancer and to that patient's individual needs.